welcome to a special web meeting, episode 2. And it is my great pleasure to participate this special webinar meeting as a chair. And I would like to first thank APG and HIFE giving me this opportunity. So now we are going to start. Maybe I'm going to introduce Professor Chang.
Yeah.
Okay.
Yes.
Okay. So Professor Chang, Superintendent Chang Hospital, Taiwan, and President Taiwan Association for Minimally Invasive Gynecology, and Chief Supervisor, Taiwan Association of Obstetrics and Gynecology, and also President-elect of Asia Pacific Association of Gynecology and Endoscopy, APG. Next slide, please.
Yes, thank you, Dr. Tsutsumi. It's my honor to be here to introduce Dr. Tsutsumi, especially this COVID-19 pandemic period. I'm very happy you are well now, and I hope you also keep your body good, especially this period. Dr. Professor Tsutsumi Osamu actually is my best friend. We have a lot of time joined together for the international meeting. He is a professor graduate at the School of the International University of Health and Welfare, Director Sano Hospital, Japan. He also is an auditor and past president of the Japan Society Gynecology and Obstetric Endoscopy and Minimally Surgery Therapy. Also past president of the Japan's Society of Fertilization and Implantation. He is also the past president and the past Congress president of the AIH and president of the OB/GYN PRP treatment study group. So we have. I am very happy here to introduce Professor Tsutsumi, wonderful professor, and I hope after meeting the Professor Tsutsumi, he will give us a wonderful comment. The next one, I will also introduce the other wonderful doctor, and she is the speaker, Professor Aruna Adharan. Professor Aruna Adharan, he is the associate professor, Department of OB/GYN, University of Malaya. Also secretary. Gynecology Endoscopy Society of Malaysia, and also Vice President, Young APH Group, and while also Vice President. And he is also President and Chief of the University of the Malaya Medical Alumni Association, and also the APH Committee member. And Professor Dr. Adharan, I will be Lincoln Chang'an Memorial Hospital. She is a wonderful doctor and is very kind. And I'm very happy and my honor here to introduce this wonderful doctor. Dr. Adharan will give us a very wonderful topic. He will talk about the diagnosis of placenta preta and cesarean section, the scar pregnancy. Actually, we are OB/GYN doctor. We all know this topic is a very important because maybe it's the crisis of your early pregnancy, the woman and mother. So that's it. Welcome, Dr. Aruna Adharan, please.
Thank you very much, Prof. Chang. It's so nice to be called back again to present on something. Can you see my slide?
Yes, I can.
Okay. Thank you, Professor Lee and Professor Tsutsumi for inviting me over for this talk. Now, I have been given the task of actually talking about the diagnosis of placenta accreta and cesarean pregnancy. And specifically, we are to be looking at the clinical protocols and its outcomes. So, yes. All right. So, yes, that is me. Thank you again for this invitation. Now, let me just take you back again through to the definition so that we are clear in a very short period of time. What was previously known as a morbidly adherent placenta okay, is what we now know as a placenta accreta spectrum. And that includes the increta, okay, where it is, the placenta is attached to the myometrium, okay, and the accreta, which is what we usually know when it is, it is attached to the uterus, okay, the placenta is attached to the uterus. Hang on, let me see, am I blocking? Okay, it attaches deeply to the uterine wall, but if it undergoes increasingly, it enters into the uterine muscle, it becomes an increta. And when it goes completely throughout the myometrium, sometimes even penetrating into the bladder, we call it a percreta. So we understand that it is because of a defect of the endometrial myometrial interface. So there is a failure of normal decidualization in the area of the uterine scar. Okay, so this will now allow deep placental anchoring villi and trophoblast infiltration. Okay, so what happens is that usually the risk factors are perhaps a previous cesarean delivery and previous number of cesarean deliveries. Now, in general, across the board, all right, the generally accepted practice is for a cesarean hysterectomy to be done, either immediately or a delayed cesarean hysterectomy, in the sense that the placenta is removed first or the placenta is left behind and immediately we take out the whole thing. So I hope that this webinar will shed us some new ideas on what else we can do for these patients. Okay, so I have collaborated and taken 3 consensus. One is from America, okay, and from the American College of ONG, we can see that the recommendations are always about making sure that you diagnose it properly with an ultrasound and managing the placenta accreta patients early within the antenatal period, having a standardized approach in a multidisciplinary care team, okay? And for a delivery to be early, within 34 to 35 weeks, or maybe 37 weeks at the most. And when there is hemorrhage, there must be support with a rapid transfusion protocol, and expected management, if any, should only be considered as long as the patient understands, okay, the uncertain benefits and efficacy of the situation. All right, so these are the recommendations. The British recommendations are a little bit more detailed, but nevertheless, it also covers similar things in the sense that the antenatal diagnosis is important, okay, and if they require a cesarean section, all right, we must alert the antenatal care team of this higher risk, okay? And they also identified that the diagnosis is an ultrasound, and I will show you later where they incorporate the usage of MRI. All right. With the Australian and New Zealand protocols, okay, it is stated, it's a very short protocol, but they say that placenta accreta is difficult to diagnose, but if it is diagnosed, then again, it is the optimization of maternal hemoglobin, iron stores, and medical facilities. Again, they emphasize here, has to be available potentially for a hysterectomy and massive blood transfusion. So in essence, all 3 believe in that. Okay, hang on. It has, okay, it has gone a bit too far. Okay, so all right. Okay, hang on, it went a bit too far. Yeah, okay, we're here. Okay, so all 3 actually come up to the same conclusion. It is the diagnosis of using an ultrasound. We can incorporate MRI and a multidisciplinary team approach to support in the event there is a need for a hysterectomy and blood transfusion. Within the American guidelines, they specifically mention what is to be done pre-operatively, intraoperatively, post-operatively, and it all very much is detailed into a surgical preparation. situation. Okay, with the British also, again, I think here it is a repetition, but they also now suggest that yes, you can use an MRI, and the absence of risk, they still suggest a delivery between 35 to 36 weeks, but they suggest also that larger studies are needed to look into the efficacy of radiology, okay, in the diagnosis of placenta accreta spectrum, okay. And the role of interventional radiology needs to be discussed. It is not very clear. With the Australian guideline, again, they repeat about the usage of cell saver, that they must remain close to the hospital for worry that they may bleed and hemorrhage. So the timing of the cesarean section should be considered desirable to perform it as an elective rather than that of an emergency procedure. So I know it is a bit of a messy slide, but I have taken, I wanted you to see that in essence, they seem to agree on the general management of the placenta accreta. So for the Americans, the hysterectomy is the typical treatment. They highlight, of course, the complications are hemorrhage, injury to your pelvic organs, loss of future fertility. And there are techniques of removal of the placenta, repairing the resulting defect, or even removing the placenta and putting in a Bakri balloon. And some have also advocated placental cord ligation, and then we leave it inside too. But of course, a patient has to be counseled regarding the risk of infection, sepsis, etc. The British are a little bit more conservative. It is still a cesarean section hysterectomy. And looking at the data with the Green Top guidelines, also they say that a uterus preserving surgical technique should only be attempted by surgeons working in teams, expert surgeons, okay, who have the expertise to manage such cases. And they highlighted that there are not enough data to suggest that you should stent the ureters in case, you're worried about involving the ureters. There is currently insufficient data, but it may be a role if you feel that the urinary bladder is going to be invaded, or at least intraoperatively, you see that it is invaded by the placental tissue. So limited evidence to support uterus preserving surgery in placenta accreta, and they should be informed of a high risk of peripartum and secondary complications, including the need of a secondary hysterectomy if the uterus was preserved in the very beginning. Right? And again, in the Australian guidelines, the idea is to deliver the placenta through an incision away from the placenta. This is the recommendation. Trim the cord close to the insertion site, repair the uterus. Okay, you can do that. And it can be a conservative management, but nevertheless, data has suggested that 2/3 of them, you may avoid a hysterectomy, but 1/3 of them would still require a hysterectomy because of this uncontrollable bleeding. So yes, I have put it up there again. You can take your time to read on that. With regards to hysteroscopic resection of placental remnants, now a large study shows that there were 12 women, okay, who underwent hysteroscopic resection. One required a hysterectomy subsequently, but there were 9 successful cases, okay? And they picked up a study with HIFU in conjunction with the hysteroscopic study resection, meaning to say that HIFU was performed and subsequently followed by a hysteroscopic resection. Success in all 25 patients, but 9 patients required more than 1 hysteroscopic resection. 2 patients had uterine perforation. 1 actually had hemorrhagic shock and required emergency uterine repair. So their conclusion is that given the limited data, frequency of adverse events and proportion, and patients needing a repeat procedure, routine hysteroscopic resection with or without high intensity focused ultrasonography at that point was not recommended. Okay, so I am interested to find out our subsequent speakers as to how we can sort out this issue. Okay, similarly, nothing different from the American guidelines as well. Elective peripartum hysterectomy may be unacceptable to women desiring uterine preservation, but you know, if it is considered inappropriate, leaving the placenta in situ should be considered. But you need to remember that they can still go into a sudden requirement of if the placenta is left in situ, then you need to monitor that to make sure that they do not have any complications such as bleeding or infection. Methotrexate adjuvant therapy, we know has been started and been used, but it is their recommendation is that it's not to be used for expectant management, as it has unproven benefits and significant adverse effects. But then again, this was added new in 2018. There are papers to suggest that it actually works, and I think we will show that later. Okay, so role of interventional radiology, we know that they do that for uterine artery embolization is also co-performed with hysteroscopy for such cases, particularly in cesarean scar pregnancies. And they also say that it can perhaps be managed if you can control the hemorrhage. Okay, and hopefully there is no hemorrhage that we are dealing with. Balloon catheters also suggest, you know, you need further evaluation whether or not we can put a balloon catheter in subsequently in the delivery of a placenta accreta. So the objective is, of course, to diminish blood loss. And to hasten placenta reabsorption. Okay, that is the idea of this conservative or expectant management. But uterine devascularization, that means you stop the blood supply. The principle is to put in a balloon, you know, balloon placement within the uterine artery, or you might want to embolize the uterine artery, or even for that matter, ligate. So the whole idea is actually to stop this blood loss. Now, post-delivery methotrexate is also another technique that people do. This is supposed to help with the placental involution, shrinking, and resorption by the system. And there are also people who suggest and they do a delayed interval hysterectomy, which is later. So that is also up for discussion within this webinar session, I reckon. So in summary, placental accreta spectrum is increasingly common, and I have done a lot of reading, particularly within the Chinese nation, where now they have a two-child two-child concept, that cesarean sections are more common. So on the range of about 1 to 2,000 cases, you may have a cesarean scar pregnancy, for example, which we are going to cover after this. But we also know that it is a significant morbidity and mortality. And so at this point in time, with a PAS, a placental accreta spectrum, we know that we need to know the risk factors. We need to know the antenatal imaging. Okay, we understand that a cesarean hysterectomy could be the penultimate or the final procedure that needs to be done. Okay, then it is the most accepted approach by many at this point in time. So if we are talking about a conservative management or expectant management, it is only for carefully selected cases, okay, after detailed counseling. And at this point in time, the recommendation is that it is only considered as investigational. All right, so now let's get into the cesarean scar pregnancy. It is rare, very rare, but nevertheless, it does happen. And out of 500 plus cesarean scars, there could be one which ends up with a cesarean scar pregnancy. Some say that it is almost like an ectopic pregnancy. Okay, now usually diagnosed within the first trimester. And if you do not treat it, it subsequently can become part of a placental accreta spectrum. Okay, so the gestational sac, okay, is embedded in the uterine window at the site of the actual cesarean scar where you actually perform the Caesar. So if you allow this pregnancy to happen, all right, the risk of placenta accreta spectrum is just 100%. All right, so there are criteria to it. Okay, so one is that when you put it on ultrasonography, I will show you the pictures. Okay, so On the ultrasonography, you will see the criteria will be an empty uterus with a good endometrial lining that you can see, perhaps a gestational sac at the end near to the isthmus, okay? And you will see if you put on the Doppler, peritrophoblastic invasion, and the Doppler, there is actually vascularization within the area of this isthmus. And if it is a bit more advanced, you can also see thinning of the myometrium, and the plane between the myometrium and the bladder can actually be compromised. Okay, so the Chinese Medical Society have actually typed the they have categorized the cesarean sections pregnancy, cesarean scar pregnancy into three. One which is closer, okay, closer, mostly located within the uterine cavity, but some of it, okay, it's closer. And then type 2, partially implanted, but majority of it is still within the myometrium. And type 3, where it is almost extruding outwards, okay, extruding outwards, and it almost appears like it is towards the bladder. Okay, so you can see the myometrium is really significantly thinner. So that's a type 1, 2, and 3. So very much the current novel approaches depend on the grade of the CSP, grade of the CSP. All right. So again, I'm going to recap. The diagnosis is an empty uterine cavity, okay, clearly visible endometrium. You see the gestational sac at the anterior isthmus or the cesarean scar. There is a lack or diminished myometrium between the bladder wall and the mass, okay, or it could be like a complete discontinuity. You can't see the anterior muscular tissue. And when you do a Doppler, you can see high blood flow, high velocity, but a low impedance of the peritrophoblastic flow surrounding the gestational sac. Okay, and one test that you can do is that when you apply gentle pressure to the cervix, the gestational sac does not slide. So that means it is, part of it. It's part of it. All right, so here are some pictures to suggest. Here, empty uterus with the endometrial lining. You can see here the sac, endometrial lining, and the bladder pretty near. All right, velocity, high velocity, low impedance, peritrophoblastic invasion, blood supply over here. All right. And so I sometimes feel like it is easier to relate if there is a case. So I picked up a case that happened to us this year within the University Malaya Medical Center, where she was a 43-year-old gravida 4 para 2+1 who actually underwent assisted reproductive therapy because of an unexplained secondary infertility. And what happened was that she presented at 21 weeks in this pregnancy with a persistent vaginal bleeding for a month. So when we scanned her, and that was at 16 weeks, an early scan, it was a small fetus with a low-lying placenta. So of course, the idea was to admit her for a threatened miscarriage. She was treated with utrogestan, dufaston, NTD, and the sort, but she had multiple episodes of pervaginal bleeding. So at that point, at 25 weeks, we thought, okay, this could be antepartum hemorrhage due to a low-lying placenta. She was administered steroids, but as weeks went by, the serial scans, we were even more suspicious of this placenta accreta spectrum. So could this actually be a cesarean scar pregnancy? And then what happened was that she was kept in the ward for the longest time until she was about 35 weeks, okay? And she had one episode of pervaginal fluid. So we knew at that point it was a PPROM. It was a pre-labor, premature rupture of membranes. And she underwent a cesarean section. And what we found was that there was placental invasion at the uterine serosa. So she bled for about 2 liters. We had to transfuse her with 1 pint of packed cells. And when the cesarean hysterectomy was completed, we sent it for a histopathological examination it came back as placenta increta with adenomyoma. So can we see here that there is a loss of plane between the bladder, okay, and the uterus? This was what we had. We had a CT scan, an MRI, a CT scan of this patient. There's a loss of plane. Okay, and this was the resultant hysterectomy. So the baby was delivered, but nevertheless, we chose not to save the uterus because for fear of bleeding. And you can see the really thin border there, okay, and that was the placenta. All right, that was the placenta. So when we go through protocols and how, around the world, what do people do? I picked up this study, which, looks at what happens when you have a cesarean scar pregnancy with a positive fetal heartbeat or with a negative fetal heartbeat. But what came about was that, almost 40% had severe bleeding. And if they did progress to the third trimester, some ended up with a uterine rupture, hysterectomy. Unfortunately, well, there was no maternal death here, but with the negative fetal heart, even if they wanted to perform a conservative management, and usually this was within the first to the second trimester, they do undergo, yes, many actually just have like an uncomplicated miscarriage, but there are about 30% or so which ended up with a complicated miscarriage. Thank God there was no hysterectomy needed or maternal death. So a Turkish study came out with this protocol where if you do have a cesarean scar pregnancy and the algorithm is as such that if there is a fetal heart and if your patient requires for a termination of pregnancy, then you've got to think about the most appropriate treatment. Okay. If they want to continue the pregnancy, then we have to decide whether this is high risk for increta, percreta, and risk of cesarean hysterectomy, or if it is at the scar itself, what do we do? Is it low risk? If there is no fetal heart, the protocol suggests that you follow through until the beta HCG becomes 0. All right. So in summary, if you have a positive fetal heart with the cesarean scar pregnancy, you are worried about now severe hemorrhage, early uterine rupture, hysterectomy, and severe bleeding. Okay. If there is a significant proportion that may go to term, like the patient that we had, it is questionable whether termination should be the only therapeutic option that is offered. Maybe they don't have to be terminated. All right. But with the negative fetal heart, expectant management can be a reasonable option. All right, in view of low likelihood of maternal complications, as we showed just now, but patients still need to have a close surveillance, okay, to make sure that there is no severe outcome. So with regards to treatment modality, we look through the literature and what we can find is expectant management, systemic or local methotrexate. Systemic is through the intravenous or systemic, sorry, not intravenous, it's systemic as usual, and the local is actually guided, ultrasound guided into the area of the suspected cesarean scar pregnancy. Some do needle aspiration with MTX. Okay, uterine curettage seems to be quite commonly done. Hysteroscopy. Some even try to do, and this is a novel idea, of a transvaginal curettage. So between the border of the cervix and the anterior fornix, a transverse resection is made where it is then removed, but it's novel. Then you have the uterine artery embolization followed by the curettage and hysteroscopy. I would be most comfortable with the laparoscopic cesarean scar resection, push the bladder down and then locate the area perhaps with vasopressin and cut the area and suture it back. That will be good for the type 3 of the cesarean scar pregnancy. And many have also reported cases of repeated HIFU ablation, okay, high intensity frequency ultrasound, and also making a pairing of HIFU plus hysteroscopic suction and curettage. So let's wait and see what the other speakers have said. So we looked at it. Systemic review shows that there are so many ways. Okay, there are more than one way to skin a cat. So many ways. And even in this group where the first protocol was a wedge resection, okay, just to remove the area. Protocol 2 was a suction curettage. Okay, so protocol 1 is laparoscopically done. Suction curettage hysteroscopically. Systemic methotrexate. Protocol 4 is systemic plus local methotrexate. But inevitably, it did not show major differences. Nothing much different aside from hemoglobin levels, because perhaps the surgical ones, there's a drop of hemoglobin. But in terms of days of discharge, in terms of waiting for the beta HCG levels to come down, the beta HCG levels come down slower within those with the methotrexate format. Okay, so summary says that there are not really much significant differences. So the best would actually to select the most appropriate protocol after discussing with your patient. Okay. All right. So here are my references, and this is the lady whom had that placenta increta, and she has survived, thank God, and she is now a spokesperson for a blood donation, and that is the the joyful baby that came out of it and who stayed with us for the duration that she had to stay within the hospital. So I hope I have managed to define and tell us, remind each other where we actually stand. And perhaps at the end of this webinar, we can close the gap by getting new and a little bit more predetermined ideas on what we shall do with cesarean pregnancies, cesarean scar pregnancies. Thank you very, very much.
Yes, thank you, Dr. Aruna. It's wonderful, very wonderful topic. Is there any question? Aruna, actually, I have one question.
Yes.
You ever talk about the uterine artery embolization, right?
Yes.
If the patient have one more baby, do you
no.
do you use the TA?
No. Yes,
No.
you are very right. Thank you, Prof. Chi, for highlighting that. Uterine artery embolization, we have to counsel the patient that we do not know its effects on the uterine, on the endometrial function and quality subsequently. So if they are in need for another a child, we have our reservations to promote that idea.
Okay, well.
Because
so
of the
I have the,
embolization.
yeah, please. Okay. I have the other question. Yes, do you use the Doppler to check the accreta or increta or cesarean section scar precursor, the blood flow? Do you use?
Yes, we do.
Yeah, okay.
Doppler ultrasound.
Any comment about the Doppler flow? Because actually it's not, maybe it's not give you a definite diagnosis, because maybe there is the neovascularization. Do you have any experience about that?
Well, we don't get many cesarean scar pregnancies. So the 1-2 that comes to us, most of it is basically ultrasound, as I said, the criteria to see the location. The Doppler is like an adjuvant or an additional help, if any. But you might be right. Yes, you are right, because sometimes the vascularization can be also impaired. We have not yet used the MRI, but it is being suggested that MRI is recommended. What is your opinion? Do you depend on that?
Actually, I don't use it. Yeah, but my experience here is if you use the Doppler flow to check the flow,
Yep.
but actually just give you some message only. Sometimes it's very severe, but you get inside, maybe you open laparotomy, but it is the very soft adhesion only. So I can remove the accreta, the placenta, very easy. At that time, I always say that, thanks God. Thanks God help this mother. Yeah. Is there any question? Professor Tsutsumi, do you have any experience and any comment give us?
Yeah. Thank you for your very beautiful presentation. And I am interested in expectant or conservative management of placenta accreta. And you have shown MTX and HIFU. Do you yourself have experience or some, do you know some paper describing this procedure?
There are quite a few papers describing the usage of MTX with curettage, but I have not seen MTX with HIFU. Yes.
Not yet.
Yeah, no, I've not seen that. I mean, I was looking through there because there are not many cases. I mean, I touch wood, thank God I don't get many cases of such in my practice. So I was looking at all the papers and there is a lot of usage of MTX followed by curettage. But interestingly, as you said, Professor Sumi, there is no MTX plus HIFU. Do you think that it may work? Is it necessary? Because I would have thought HIFU would, act on it immediately. Already you don't do MTX.
Yeah,
So,
MTX maybe get it smaller, and HIFU maybe acting
Smaller.
Smaller. And finally, maybe hysteroscopic
will be
removal,
better.
maybe
In
combination of many treatments.
The literature also suggests that the gestational sac is only approximately maximally about 9 millimeters. So it's it's not
maybe
so big in the first place. So that's that.
Sorry, we are talking about cesarean scar pregnancy, right?
Yes.
Okay. So, Professor Tsutsumi, do you have any MTS for scar pregnancy experience? Do you?
I have no experience of usage of scar.
Okay.
But we sometimes use MTX for placenta rest or ectopic pregnancy. And recently, we are going to try GnRH antagonist or agonist to reduce hormone level. We are now trying it.
So how about the Adana? If you have the pregnancy in Creta, placenta in Creta or Creta, after surgery, the patient is good, very good, and the recovery wonderful. After that, do you use the MTS injection for her?
No. Not in my practice.
Okay. So if the patient want the children or the other baby, do you recommend or you do something for her?
That is very controversial,
Yeah,
Dr.
it is.
It is very controversial because I think then we have not much experience. We don't use MTX for placental resorption. We say that we try to preserve the uterus, but inevitably it is still life over pregnancy. So I think most of our patients also, they understand in that sense. Yeah.
Actually, the MTS, the other problem is how many doses do you use? Local injection or general injection, IM injection, or how many doses you use? That is the problem. Is there any question? It's a wonderful topic. Is there anyone comment or any question? Okay. If you have no any question, we
Hello.
Hi,
Hi,
yeah,
everybody.
yeah, okay. You are
Can you listen
Zina,
me?
right? Zina? You are Zina, right? Do you have the
Hello.
question?
Can you listen me?
Yes, I can.
Thank you
you?
very much for
Do you
thank
have
you
a
very much
question?
for the wonderful lecture. Just I am wondering that is there any preventive role during C-section to prevent the scar pregnancy? My first question. And the second question is that the most of the literature says that the role of MTS, that is methotrexate, is really insignificant. So how far it is true? That's two questions to Dr. Zira, which is wonderful. Thank you very much.
Thank you, Dr. Zina. I agree. Literature also says that the role of MTX is questionable because in most of their treatment protocols, they actually incorporate the suction and curettage or a hysteroscopic evacuation. That's one. So yes, I question that as well. With regards to cesarean scar incision and repair, I came across something quite interesting. It says that nowadays people are suturing only one layer. Is that common?
1 layer.
One layer. So I don't know. I mean, here.
Yeah. It's many obstetricians, they like that, but I don't do personally.
Yeah, exactly. So the literature review says that if you have 500 cesarean sections, scars, maybe one will end up, but I think that number is, no, it's not 1 in 500, it's like 1 in 2,000 or so. So that's quite rare. One will end up in cesarean scar pregnancy. But I think the fact that it is such a rare occurrence as well, it's a bit difficult. It's a bit difficult to find studies and recommendation. Do you have any suggestions yourself, Dr. Zina? Maybe you have suggestions on how to improve cesarean scar.
Well, actually, I didn't find anything in the literature. That's why I was wondering that probably you will know better than me.
Yeah, I came across it's 1 in 2,000 Caesars. And apparently it is rising now because more and more people are opting for cesarean section.
Okay.
It's true. That's true. I was yesterday in RCOG Congress in the London, and they also discussed a huge 1 hour session on PAS. So Khalid from Saudi Arabia, he delivered an excellent lecture. What he suggested that you can draw a line on the scar or on the PAS. If it is above the scar, probably you can allow the patient to continue pregnancy. It is not that dangerous. But if the scar of pregnancy below the line, that line is dividing the uterus into two parts. So that is a wonderful message, what we learned yesterday from the RCOG Congress in London. Thank you.
Thank you.
Okay. I'm afraid we must go to the other session. So I must close this session. So Professor Tsutsumi, it's yours.
Oh, thank you very much. I would like to invite the next speaker, Dr. Lee Ja-sung. His title is Clinical Experience of Ultrasound-Guided HIFU Treatment for Gynecologic Disorders at the Single Center in South Korea. Next slide, please. Yeah. The first HIVE doctor in obstetrics and gynecology of South Korea, and participated Congress as a lecturer. For example, the first Young International Summit of Minimally Invasive and Non-Invasive Medicine. And he had published ultrasound-guided high intensity focused ultrasound treatment for uterine fibroid and adenomyosis, a single center experience for the Republic of Korea. And he had so many papers, and he's one of the leader of Korean gynecologist, and he has very experience in HIV treatment. So we are going to invite him to give us a lecture. Professor Dr. Song, please.
Thank you. Good evening, sir. Hello, nice to meet you. I am Jae-sung Lee from South Korea. I am the first Chungching HIV doctor of Korea and the first gynecologist HIV doctor in Korea. I have treated uterine fibroid and adenomyosis by HIV during 13 years, from 2010, and now I have treated about 2,900 HIV cases. I have used JC and JC-Evective model for HIV treatment. I hope my experience of HIV may help you take care of your patient in your hospital or in your clinics. I will present 13 years my HIV experience. As you know, 3 effects against the tumor cell by treatment with HIV appears. The first, direct thermal ablation. The second, cavitation effect, destroying tumor cell by increasing cytoplasm temperature. The third, damage to tumor nursing blood capillary, coagulation necrosis. This is the record I requested of the Ministry of Health and Welfare in June 2012 for HIV permission for uterine disease. This is issued in Korea in February 2013. After that, many doctors and hospitals have started HIV treatment. This paper for my HIV story. Until this year, I have reported some papers of HIV treatment. Demographic data of uterine fibroid and adenomyosis. Average age was 41 and average treatment time is 80 minutes. This paper, Journal of Ultrasound and Sonochemistry in 2015. The second paper was Journal of Ultrasound in Medicine and Biology in 2019. This table is a follow-up result of the post-HIV treatment in uterine fibroid. The total of 918 fibroid was treated. Uterine fibroid volume reduction rate were 55, 63, 74% at 3, 6, and 12 months respectively. Decreasing symptom severity score scale and increasing the uterine fibroid symptom and quality of life was statistically significant. The figure was shown. Total of 889 adenomyosis was treated. The uterine volume reduction rate were 45, 51, and 60% at 3, 6, and 12 months respectively. Decreasing symptom severity score scale and increasing the uterine fibroid symptom and the quality of life was statistically significant. The volume reduction rate was somewhat lower than uterine fibroid. I think that the reason why adenomyosis reduction rate is lower than myoma is the measurement of total uterine volume. In cases of adenomyosis, because I did measure the total uterine volume, the patient with adenomyosis have more severe symptoms such as menorrhagia and dysmenorrhea. They are more satisfied with the dramatic result after HIV treatment. Here I prepared some example case of hyper. 7 centimeter case of submucosal uterine fibroid was shown. Non-perfusion area was seen inside the boundaries of the tumor. After treatment in enhanced T1 weighted MRI image. After 7 months later, necrotic lesion of myoma was disappeared in the uterus. No more myoma was observed in this MRI image. In cases of hypo of uterine fibroid, complete ablation close to the capsule of myoma would be reduce the relapse rate. This case is a 5 centimeter case of multiple uterine fibroid. 9 months later, the volume of myoma was reduced by 88%, and there was no regrowing on the margin or no relapse. 34 months later, after treatment, necrotic lesion of myoma was expulsed out of uterus. No more myoma was observed in this figure. This is another submucosal myoma HIPE treatment case. Necrotic lesion by HIPE disappeared in 3 years follow-up MRI image. Submucosal type of myoma is one of the best cases for HIPE treatment. This case is a cervical myoma. The cervical myoma was growing at high vascularity site of uterus, and its nature is very soft. So, HIPE treatment of cervical myoma is somewhat difficult, and the recurrence rate is more higher. First time, this patient received HIPE at another clinics. The uterine fibroid was located uterine cervix. Previous HIPE treatment was incomplete. I used GnRH agonist for 3 months before HIPE, and then lesion over 90% was treated. After 6 months later, lesion was decreased to 2.5 centimeter size lesion, about 90-70% decrease. Some cases of rapid decreasing size was related to infection of lesion. If infection occur in HIPE region was more friable and easily detached, like pus and discharge. If you suspect infection, antibiotic treatment was needed until symptoms disappeared. HIPE can be non-surgical myomectomy and non-surgical adenomyomectomy, I think. This case was multiple fibroid. The size of uterine fibroid varied widely, and there were more than 20 in the uterus. For the best treatment with multiple uterine fibroid, important point is making type 1 myoma by pre-medication like GnRH agonist. Type 1 fibroid were easily treated by diffusion energy or cavitation effect. If you meet patients like these cases, I recommend that you use GnRH agonist about 2 or 3 months before HIPE. And then if cooling time is over 2 or 3 seconds and the total treatment time get enough, sufficient cavitation effect can be given to all myomas. This case is 8 centimeter adenomyosis cases. She had 2 babies. I treated the entire lesion except the safe uterine margin near the bowel. 42 months later, uterine volume was decreased to 82%. She feels very good well. Severe menorrhagia and dysmenorrhea was disappeared. 12 centimeter diffuse huge adenomyosis cases. She received 3 times of in vitro fertilization for pregnancy. Superovulation injection made adenomyosis worse. I treated near entire lesion. Uterine volume was reduced by 87%. HIPE treatment for adenomyosis is the best non-invasive treatment of choice, except hysterectomy. This combined case is a submucosal myoma and diffuse adenomyosis case. She had diabetes mellitus and her hemoglobin level is 7. Past he have 2 times myomectomy history. Level node gestational IUD was inserted in uterine cavity, Mirena. Submucosal myoma and diffuse adenomyosis was shown. Usually, most gynecologists treat by hysterectomy like these cases. I think that HIPE treatment can be a good treatment modality for this case. After 9 months later, myoma was disappeared, uterine size was normalized. Menorrhagia and dysmenorrhea symptoms were totally disappeared. HIPE treatment could be non-surgical myomectomy and non-surgical adenomyomectomy. I'm really emphasizing. She had huge multiple uterine fibroid over 7 centimeter, 6 centimeter, 5 centimeter size multiple. Because of multiple myoma, uterus was enlarged to 14 centimeter length. I treated over 90 to 95% of uterine fibroid. T1 weighted MRI image shows well-treated state. 15 months later, she was embarrassed because hysterectomy was recommended by a large hospital of medical university. So she came to me. I recommend her enhanced MRI. 14 centimeter size uterus decreased 7, and all treated myoma was non-enhanced stated and no new lesion. It was a very good post-HIPE treatment follow-up state. Usually, most gynecologists use diagnostic sonography, but they didn't figure out post-HIPE treatment state. Therefore, even if the treatment is well treated, hysterectomy is recommended only by looking at the shape of the uterine ultrasound image. All obstetrics and gynecologists should know that the treatment state of a patient who received HIPE treatment can only be judged by examining the enhanced MRI image. This slide is a complication analysis for 1,807 patients. 918 cases of uterine fibroid, symptom recur over 42, new lesion over 23, secondary HIPE treatment over 9, hysterectomy over 13, myomectomy over 8. 889 cases of adenomyosis, symptom recur over 39, new lesion over 17, secondary HIPE treatment over 17, hysterectomy over 20. Complication analysis. Transient foot drop of 1, and tumor-rise syndrome and pre-renal failure of 1, small bowel perforation of 2. In case of a transient foot drop and the small bowel perforation, I believe that mistake, for example, power control or interpretation of ultrasound image were made. The rest complication, first degree burn and second degree burn and transient hematria was transient and minimal severe. This paper published in 2018. Journal is Clinical and Experimental Obstetrics and Gynecology. This paper is unintended pregnancy with term delivery following ultrasound guide HIPE ablation of uterine fibroid and adenomyosis. 2017, British Journal of Obstetrics and Gynecology. I checked anti-Mullerian hormone biomarker for ovarian reserve before and after HIPE treatment. There were no significant difference in anti-Mullerian hormone level between the two time point. So we conclude that HIPE treatment do not affect ovarian function. This slide is a HIPE treatment for placenta accreta. I experienced 2 cases of retained placenta accreta. She had vaginal bleeding for 6 months after cesarean section. ultrasound images show 2 or 3 centimeter mass like myoma. With HIPE treatment, retained placenta lesion was disappeared after 3 months. Previously, I reported HIPE treatment cases report with retained placenta. In 2016, this is a Journal of Obstetric and Gynecologic Science. This is another treatment cases of retained placenta with HIPE. Incomplete abortion bleeding occur after in vitro fertilization. Dilatation and curettage was performed 2 times, but there was continuous severe bleeding. Placenta invade the anterior myometrium of uterus. Complete ablation was done for region by HIPE. After 1 month later, beta HCG level was normalized at 1 month. This is abdominal wall endometriosis treatment cases by HIPE. I experienced 2 cases of abdominal wall endometriosis treatment by HIPE. This is the first case. She had a tender nodule by menstrual cycle after laparoscopy. After HIPE treatment, the symptom was subsided. This is a Journal of Gynecological Endocrinology. Abdominal wall endometriosis treatment by HIPE ablation. The last topic is effect of a paracervical block before ultrasound guide HIPE treatment in uterine fibroid and adenomyosis. This study shows that paracervical block before ultrasound guide HIPE treatment was a cost-effective method because it helped reduce the total treatment time, ablation time, and the total energy. Also, can be helpful reducing the excessive use of intravenous sedation. This paper will be published within this year. HIPE treatment with very good therapeutic effect and acceptable side effect for uterine fibroid and adenomyosis and other solid gynecologic disease is the best non-invasive treatment so far. But be careful for patients who want a future pregnancy and informed some possibility of being in trouble of pregnancy. Enough experience are needed to make a satisfactory treatment outcome. We have to approach carefully because treatment cases are all different density and different location each other, and the treatment time and the power level are all different. I really appreciate your attention. I hope my experience might help you. Thank you.
Oh, thank you very much for your beautiful and kind presentation based on your experience, more than 2,000 cases. And I admire you publishing papers, your experiences, and congratulate on your success of publications.
Thank you.
And now it is open to discussion. And if anyone,
I have a question.
First, Dr. Chan.
Dr. Chan.
Yeah.
Actually, I have 3 questions. I also have the HIPE case. The first one, how do you, how about the energy setting in different cases? The first one, the energy setting, the first. The second question is actually you have the first degree burn about 17 case and the second degree burn about 18 case. The patient, how do you deal with this burn case? The third one, you ever mentioned about abortion after 2 times abortion operation, but the patient also have a lot of vaginal bleeding. You use the HIPE to to treat it, and no more bleeding. But I have one, the question is, this case after HIFU treatment, have a baby or not? It's my three questions. Yeah.
The first I use the hyper treatment power level is
Yeah, energy setting.
energy setting is JC 200D I used. Usually at least 350 over, and
Okay.
usually 400 power joule. Okay.
Okay. How many time? How long you spend for each patient, especially the big myoma?
In
How
many
long?
cases, I treated at 40 minutes and 90 minutes.
Okay.
It's different case and multiple case and single case, solid case is very different. And more huge sizes need to more time.
More time, right?
Time, okay.
Yeah, okay. The second one about your burn case. How do you deal with it after the HIFU treatment? The burn,
Pardon?
the skin burn.
Skin burn.
Yeah.
Many cases is the first degree burn is only dressing or 2 or 3 days, and after then and dry the skin. If we use we do not another medication, and I have no third degree burn, and first and second degree burn case easily treated and only dressing. Okay.
Only dressing.
Only
Okay.
dressing, and for prophylactic antibiotics 5 days.
Okay, 5 days. How about the abortion case? The abortion case that you
Abortion case.
Yes, you have ever mentioned about abortion. After abortion, have the vaginal bleeding, but you use the HIFU to treat it. I say the case. I am adopted like the case have before have a baby after HIFU.
A correct case or post HIFU pregnancy and parturition?
In that case, you ever mention about the abortion case? After abortion, the patient all are still vaginal bleeding. So you use the HIFU to treat it. The patient have no more bleeding. But my question is, this case have baby or not after HIFU?
I think that the before treatment lesion of myoma or adenomyosis affect the post-HIFU treatment and pregnancy. We can only ablation the myoma or adenomyosis region, but before treatment, the region was very severe. After HIFU, the pregnancy is not good. But if the region is not severe or only a single or some multiple, but some multiple is not severe, we treated HIFU after 3 can pregnant. I think that HIFU after HIFU treatment pregnancy is better than laparotomy, myomectomy. Okay.
Thank you for your answer. Thank you. And thank you for your excellent experience.
Thank you.
Oh, okay. Yeah, Dr. Lee. Yeah, your talk is interesting and instructive and provoking. And I want to ask many questions, but time is limited. Maybe I ask you two. One is pregnancy. HIFU after 5 treatment, patient in case of pregnant, maybe in surgery, after surgery, cesarean delivery, but in half case, how about the cesarean rate? Type of delivery, vaginal delivery or cesarean?
After hyper treatment, I offer to cesarean section to patient, but he want to normal delivery. Be careful if the risk of uterine rupture. You should receive the cesarean section. Okay.
Oh, so you recommend cesarean, but
Cesarean section.
in some case, vaginal delivery. Oh,
Yes.
okay, I understand. And you sometimes use GnRH agonist. GnRH agonist treatment. In some case, you presented GnRH hormone.
GnRH hormone.
Yeah. How do you select patient? Fusion or in some case?
Yeah. In cases of myoma and adenomyosis over than 10 or 12 centimeter size, I recommend 2 or 3 months I use the GnRH agonist. But less than 8 centimeter of myoma, I recommend only 1 use of a GnRH agonist. And we can choose the treatment time. Is good post-menstrual state. Pre-menstrual state is she has more edematous, and uterine fibroid more edematous is not good to hypo.
Okay. Thank you very much.
Maybe
it's time to move next talk. So thank you, Dr. Lee.
Thank you. Dr. Chang asked from the case who raised your the placenta case I experienced. The both case I didn't admission a chemotherapy to her, but if the HCG level reduction is insufficient, less than 5 level, 5 after this placenta, we should consider chemotherapy such as methotrexate in addition. Okay.
Thank you for answering another question. Thank you very much. So maybe next.
Okay. Thank you, Professor Tsutsumi. Now I will go to the other session about HIFU. We have the wonderful speaker, 张彩。张彩教授，你要用英文演讲吗？还是中文？
Yes, I will talk in English.
Okay, good. We have the wonderful speaker, Dr. Zhang Cai. Actually, the Dr. Zhang Cai is the senior HIFU doctor and also the very wonderful, well-experienced tutor, and have a lot of have a lot of the experience. Also, is a membership of the International Society of the Minimal Invasive and the Virtual Surgery, and also the reviewer of the International Journal of the Hyperthermia. Dr. Zhang ever provide clinical training of the HIFU treatment at home and abroad, and ever been South Africa and Jordan and South Korea, and to help to establish the HIFU center. So he also ever training more than 15 domestic doctors and more than 20 international medical staff, and have the complete about 4,000 HIFU treatment case. So it's well experienced doctor and the tutor. So let's welcome Dr. Zhang.
Okay.
Now,
So,
you will give us the topic is the HIFU, followed by DNC to treat the cesarean scar pregnancy, the clinical protocol and the outcome. Please, Dr. Zhang.
okay. So can you see my screen?
Yes, now.
Okay. So thank you, Dr. Chang. I'm Zhang Cai from National Engineering Research Center of Ultrasound Medicine. Today, I will talk about HIFU followed by dilation and curettage to treat cesarean scar pregnancy and the clinical protocol and outcomes. My talk will include 5 parts. So first is the background about the cesarean scar pregnancy. It is defined as the gestational sac implants at the scar side of the previous cesarean section on the lower anterior uterine wall. We can see that here is a wedge shape, and this area suggesting possible impaired healing. And it is reported that the prevalence of cesarean defect in women with cesarean section is up to 84%. And this kind of disease is first described in 1978. And the incidence is rare, but is between 1/1800 to 1/2200, and it accounts for 6.1% of ectopic pregnancy with a history of at least 1 cesarean delivery. And in recent years, the risk and the incidence of the CSP has been increased. We can see from a report from 2010 from the World Health Organization global survey, it showed that in Asia, the cesarean section rate is about 27%, and in China is extremely high as 46%. And here is another report by our Chinese people in 2014, that is 4 years later. This rate is increased to 55% for the cesarean section. So because the cesarean section rate is increased, so the risk of the cesarean scar pregnancy is also risk. And in the past 2 decades, I searched the literature. We found that the publication about CSP from in the past 2 decades is more than 1,100 papers, and we can see it here is uptrend. And also we can see that the highest number of publication is in China, followed by the North American and the England. And the types of CSP, it has been introduced for the first lecturer, that is Professor Adlan. And I find here is an international classification. It is divided by 2 types. The first type is the endogenous type, that we can see the gestational sac is totally inside the uterine cavity. And the type 2 is the exogenic type. So we can see that the gestational sac is growing outside and to the bladder and to the abdominal cavity. So this is an international classification. And also, as Professor Adlan said, that in China, our Chinese domestic classification also has a little bit different from the international's one. So here are 3 types. The type 1 and the type 2 are the endogenic type, but the difference is that, so for the type 1, that the most gestational sac located in the uterine cavity and only partially implanted in the scar. And the thickness of the uterine myometrium between the bladder and the gestational sac is more than 3 millimeters. But the type 2 is that the most gestational sac implanted in the scar and the thickness of the uterine myometrium between the bladder and gestational sac is no more than 3 millimeters. So this is the difference between these two types. And also we have the type 3. So the type 3 is that the gestational sac completely implanted in the myometrium of the uterine scar area, and it protrude outward to the bladder or to the abdominal cavity. And also in this consensus, they introduced a subtype of the type 3, that is the mass type. So in this type, it is usually after the CSP abortion. So if we do the ultrasound check for the patient, we can see in the scar area, here are the mixed ultrasound echo, because the mass has the cystic and the solid tissue inside, which including the residue of the scar pregnancy and the hematoma. So this is a Chinese classification. And what is the risk of CSP? So here I talk about 3 risks. The first, the bleeding during the first trimester of pregnancy. And the second, the increased risk of massive bleeding from the side of the implantation. And the third is that the uterine rupture because of the deep implantation and the growth of the gestational sac. And the last 2 are life-threatening. And for the treatment of the CSP, we should know that there is no consensus for the management of the CSP. The aim of the treatment is to first try our best to preserve the patient fertility. And the second is to prevent the life-threatening complications, including the massive hemorrhage and the uterine rupture. So these methods are all have been used to treat the cesarean scar pregnancy. The first one is medical therapy, in which the MTX is the most used, including the local usage or the general usage. And also we use the, And we also use the uterine artery embolization and dilation and cartilage, laparoscopic excision, hysteroscopic resection, and hysterectomy. In the past, more than 10 years ago, I think the high intensity focused ultrasound, which is HIFU, has been introduced to treat the CSP. And so let's talk about the HIFU treatment of the cesarean scar pregnancy. Before we talk about the treatment of CSP, let's review the principle of HIFU. So the HIFU is that the high intensity focused ultrasound waves are focused at the focal spot by the transducer, and to increase the focal spot, the temperature is more than 65 centigrade, and the coagulative necrosis is induced. And also we need to know that the effect of HIFU is not more than, not only the heating effect, it has 3 effects, including the heating effect, cavitation effect, and mechanical effect. So how HIFU to treat the cesarean scar pregnancy? We recommend the combined therapy, which is the HIFU plus the ultrasound guided DNC, or HIFU plus the hysteroscopic DNC. So what is the role of HIFU in CSP? So the first is to reduce the risk of the massive hemorrhage during the following DNC, and to minimize the damage to the uterus because it is non-invasive, and to keep the integrity of the uterus, and maybe can give the chance of quick recovery of the implantation area, and to shorten the interval between the scar pregnancy and the following pregnancy. So for the HIFU treatment of cesarean scar pregnancy, we have the inclusion criteria and the exclusion criteria. For the inclusion criteria, the patient should be more than 18 years old, and we recommend the type 1 CSP, which is endogenic CSP, and the gestational age is no more than 10 weeks, and the size of the gestational sac is no more than 5 centimeters. And for the exclusion criteria, and there is no active vaginal massive bleeding, and patient should not have the risk of highly risk of the uterine perforation or the rupture. And if the patient have the acute inflammation of the reproductive system, the patient is not suitable for HIFU. We need to control her infection first. And the previous high dose abdominal radiotherapy is also the exclusion criteria. And for the last one is the technical exclusion. Is that if we have the intestinal adhesion in acoustic pathway, that means when the ultrasound go past the bowel, there is a high risk of the bowel injury. So we should not do HIFU treatment for this kind of patient. And so what is the HIFU protocol of the CSP? So first, if the patient have been diagnosed of the cesarean scar pregnancy by the ultrasound or the contrast MRI, and also the patient is meet the inclusion criteria I mentioned before, and the patient can be prepared to do the HIFU treatment. So pre-treatment, we need to do some preparation, including the diet preparation and bowel preparation. Bowel preparation, we can do the catharsis and also the enema. Enema is not the standard or the compulsive. And we also need to do the skin preparation, including the degas and degrease, and also the catheterization before the HIFU treatment. And then we do the HIFU treatment for this kind of patient. After the treatment, after HIFU, about 2 to 3 days, and we can do the ultrasound guided or the hysteroscopic DNC for the patient. And then we need to monitor the patient or need to follow up the patient strictly, especially for the serum beta HCG and the decrease. And we need to maybe to do the serum check every week. And we also need to monitor the patient for the vaginal bleeding duration and follow her up for the time of her menstruation return to normal. So this is the HIFU protocol of the cesarean scar pregnancy. And let's talk about the HIFU treatment. So what is the HIFU treatment for the CSP? The purpose for HIFU is that we can ablate the nutrition vessels of the gestational sac in the scar area. And then we can lose the tightness between the gestational sac and the implantation myometrium. So our focus should be, so this green or the yellow dot represent the focus. So this focus should put in the implantation area, and then we can get the significant hyperechoic scale changes. We can, I can show it in the next slide. So in this slide, I want to show you how to evaluate the HIFU effectiveness. So during the HIFU treatment, we have the real-time ultrasound. So the real-time ultrasound can show us that the significant hyperechoic scale change. We can see that this is the before HIFU and after HIFU, the implantation area has totally changed, the scale totally changed. This is the intra-treatment evaluation. And immediately after the HIFU treatment, we can do the contrast enhanced ultrasound after HIFU. And we can see that the implantation area, which we ablated, we have the non-perfused area or the low perfused area. So this is the two ways to evaluate the HIFU effectiveness. And for our HIFU doctors, we also want to optimize the HIFU treatment. So what kind of the sonication strategy is better for the treatment of CSP? Here is one study conducted by a team. So the retrospective analyzed their treated patient, and they use two kinds of different sonication strategies, and they divide the patient into two groups. The first group is the C-shape sonication, and the other is the I-shape. I will show you what is C-shape and what is I-shape. So we can see from this figure that the shape, we can see that the green dot is put around the sac and in the implantation area, like a curve. And the I shape is in the implantation area and along the serrata like a line. So this is two different sonication strategies. And they first compare the baseline characteristics of the patient. We can see that in these two groups, there's no difference between these two groups for the baseline characteristics. But when we compare the HIFU treatment result, we can see that in the I shape, the sonication time is significantly decreased, and also the total energy for the ablation is decreased. So this is the HIFU treatment parameter, and also we analyzed the adverse events. We can see that in the I shape, this group, the buttock pain or the lower abdominal pain is also significantly decreased in this group. And when we compare the ultrasound guided DNC, which is followed by the HIFU treatment, we can see that the operation time or the blood loss or any other adverse events during this procedure, there's no difference between these two groups. So the authors, when they compared these two kinds of strategy, they conclude that the I shape can reduce the sonication time, the energy input, and the rate of buttock pain and lower abdominal pain during the HIFU treatment with no increase of the risk during the DNC. So they conclude that the I shape strategy may be more efficient and safer than the C shape. So this is the HIFU treatment. We're trying to do some optimization for the CSP. And next, I will talk about the comparison of HIFU and UAE, because we know that the uterine artery embolization is another minimal invasive treatment for the cesarean scar pregnancy. So what is the efficacy and the safety between these two technologies? So I find there is a meta-analysis in 2019. In this paper, the authors, researchers, they analyzed 8 papers, and from their analysis, we can see that when they compare the beta HCG normalization, we can see that the uterine, the UAE has the shorter time to get the beta HCG to return to the normal. And but for the comparison of the blood loss during the DNC, we found that the HIFU group has the less blood loss during the DNC. And when compare the adverse events, also the HIFU group has the lower rate of the adverse events. And for the comparison of the duration of the hospital stay, also the HIFU group has the shorter hospital stay than the UAE group. And also they analyzed the comparison of the hospitalization expense. This is the HIFU group has the lower expense than the UAE group. And at last, they compared the successful rate, and there is no difference. So from this meta-analysis, here is the summary of their results of all these parts I mentioned before. And the researchers concluded that both HIFU and UAE combined with DNC were safe and effective for the cesarean scar pregnancy. And the patients in the HIFU group maybe have better outcomes than those in the UAE group. And HIFU may be a priority option for the early management of CSP. And then we are also concerned about the follow-up and the fertility outcomes after the HIFU treatment of CSP. So I will show you some results. So for the follow-up, I have mentioned before, we especially need to follow up some special index. When I do the literature review from all these literatures, I find that the average time for the serum beta HCG return back to normal is between 28 to 54 days. And the average time duration of the vaginal bleeding after DNC is around 5 to 7 days. And the average time for menstruation return to normal is about 27 to 39 days. And at last, the average time for gestational sac disappear is about 4 to 8 weeks. So this is from the literature review. And then I will show some typical cases that my cases. So the first case is the endogenic type CSP. The 31 years old lady had para 1 with a cesarean section. Her pre-HIFU treatment beta HCG level is nearly 30,000 units. And here is her ultrasound and the MRI imaging before HIFU treatment. And here is the real-time ultrasound during our treatment. So pre-HIFU treatment, we can see the gestational sac very clearly. And here is the implantation area. And during the HIFU treatment, we can see the scale change is induced. And after the treatment, the whole area has this scale change. And immediately after the treatment, when we do the contrast ultrasound, we can see that here has a non-perfused area in this implantation myometry. And we do this patient for 200 sonication time and within half an hour. So 4 days later, we do the DNC for her and we monitored her or followed up her for the beta HCG for several weeks. And we can see here, the beta HCG level is decreased sharply. And when the time go to 52 days after DNC is almost the normal. And this lady, I need to mention that 8 months later, she had another pregnancy, which is the intrauterine pregnancy. So the case 2 is another endogenic type CSP, and she has para 3, and all these 3 babies are the cesarean section. And this patient, she has gestational sac implanted, and the myometry thickness is no more than 3 millimeters. And we can see pre-HIFU treatment. Here is the gestational sac. And after the treatment, we can see the scale change. And we also do the DNC 4 days after the HIFU treatment. And 5 days after the DNC, the beta HCG decreased dramatically. And then we discharged her from the hospital. When we followed her up in the outpatient, we can see that 22 days after the HIFU and DNC treatment, the lady's uterine, the uterus becomes too normal, and here is nothing in the implantation area. So the third case is a mass type CSP, and this young lady has 1 periton and with cesarean section, and she had amenorrhea for 81 days. And she had done the abortion in the clinic. And before her go to, which is 1 month before her go to our hospital. And after the abortion, she complained about the persistent mild vaginal bleeding. And the beta HCG is not so high, but when we do the ultrasound and the contrast MRI for her, we can see that here is a mass in the scar area. And we can see from the T2 series, the signal is heterogeneous. So because this patient wants to keep her uterus and to keep the fertility, and we choose HIFU for her. And we do the HIFU, and after the HIFU, because the HCG is not so high, we decided not to do the DNC for her and only do the strictly follow-up. And we follow up her by the ultrasound for 6 months. And we can see that after 6 months, her uterus come back to normal. So this is our 3 typical cases. And we also concerned about the fertility outcome. This is one of my paper published in the International Journal of Hyperthermia. And our team retrospectively reviewed our treatment, the HIFU treatment and the DNC for the cesarean scar pregnancy. And we found that in the 154 patients, there are 28 patients has the reproductive requirement. And when we follow up them for more than 5 years, and we found here are 23 pregnancy. And in this 23 pregnancy, here are 18 intrauterine pregnancy, and here are 3 tubal pregnancy and 2 recurrent cesarean scar pregnancy, and all of them have do the laparoscopic excision of the lesion in the first trimester. And we also followed up this intrauterine pregnancy, and we found that here has 12 patients had the full-term birth. And for this 12 patients, we can see that the average interval between the conception and the HIFU treatment is 18 months. And all the patients had the full-term gestational age. And all the baby born with the normal weight, and all of them are healthy. And here is another study conducted by another team with a larger group of the CSP patient. They reviewed the patient, the CSP patient treated by HIFU or the uterine artery embolization. And they found that here are 131 attempts to conceive. And in this group of patients, 70 patients had the intrauterine pregnancy, and here are 475 patients without fertility requirement, but 8 has the undesired intrauterine pregnancy. And then they analyzed the fertile group and the infertile group and the pregnancy group. They do the relative analysis, and they found that the risk factors for the infertility is that the age is more than 35 years old, and the beta HCG is no more than 5,000 units, and the amenorrhea time is more than 56 days. And they also has done the relative analysis for the risk factors for recurrent CSP. They found that first is the patient treated by UAE, and the numbers of abortion is more than 4 times, and the patient being symptomatic. So they conclude that HIFU seems superior to UAE in reducing the risk of recurrent CSP. So this is all my talk, and before my finish, and I will do some summary. So first, the advantages of combined therapy of HIFU and DNC for CSP. First is that the non-invasive characteristics and real-time monitoring of HIFU, and this therapy can reduce the risk of vaginal massive bleeding and also can minimize the damage to the uterine and keep the integrity of uterus and also to keep the fertility, because the cesarean scar pregnancy patients usually are very young and many of them has the desire to keep their fertility. And for the perspective, so we need to know that there are still a lot of part for the development and the research for the HIFU treatment for CSP. First, we need to standardize the protocol of HIFU, including the patient selection, clinical dosimetry, and termination criteria, etc. So for the patient selection, I have mentioned before that we recommend to do the HIFU treatment for the endogenic cesarean scar pregnancy. But I find the publication this year that this group, they did HIFU treatment and DNC, the suction carriage for the exogenic cesarean scar pregnancy. And they also report a high success rate as high as more than 90%. So I think this kind of cesarean scar pregnancy maybe need more researches to do to see whether they are suitable for the HIFU treatment. And the second is that we need to do some prospective researches of the effectiveness and the safety for the HIFU treatment of CSP. And also we need to optimize the post-cesarean scar pregnancy and to need to do some guidelines for the patient to do the following pregnancy. So this is all my topic. Thanks for your attention. Thank you.
Thank you, Dr. 张。张教授，我麻烦你看一下，底下有很多的问题要问你，你看底下一下。
Okay.
好，Thank you, Dr. 张。No wonder Dr. 张 is the HIFU mentor and tutor, and set up a lot of the HIFU center all over the world. I am very amazed. If I am free, I will go to Chongqing because I love Chongqing city. Maybe be your fellow. Okay, is there any question? Actually, we have a lot of the question show in the table.
Okay.
I think. Okay, maybe Dr. Zhang.
Yes.
Someone asked that if the HIFU work, why do you need to DNC again?
Okay. So I think, in my opinion, I think HIFU is like a pre-treatment for the DNC, because we know that for the CSP, if we do the single DNC, that has the very high risk of the heavy bleeding and the risk of the uterine rupture. But as we said in my lecture, is that when we do the HIFU ablation of the implantation area, we can ablate the nutrition vessel, because we know that in that area, the blood supply is very high. And if we destroy the vessel there, and then after that, we move the gestational sac out by DNC, and in that procedure, so the risk of the heavy bleeding should be dramatically decreased. Because in my experience, if we do the HIFU treatment before and then we do the DNC, the bleeding is no more than, usually it's 10 to 20 millimeter, no more than 50 millimeters.
Mm-hmm. Is there any chance he can go up, the gestational mass go up itself? Is there any chance?
And if you have already ablated the implantation area and you can do the contrast ultrasound to emphasize or to make sure that this area is already ablated. It's rare. The risk is rare.
Actually, you have mentioned now after HIFU for CSP, the recurrent rate is the 23/131. Actually, it is almost 18%. So the recurrent rate is a little high. Do you any about this data? Here.
So for this data, I haven't seen before, but I only through my literature review. So yes, after so for the patient to have the cesarean scar pregnancy before, no matter what kind of method she have done, if she want to keep her uterus, so she have the chance, no matter what kind of the method have done, she has a chance to have a recurrent cesarean scar pregnancy. But when we compared the HIFU with the uterine artery embolization, the rate is lower than the uterine artery embolization. And also, I think the doctors have mentioned before that if the patient has the desire to have another baby, so the UAE is not recommended for her, but HIFU can be another choice for her.
Thank you. Is there any question?
So may I have? Yeah. Thank you for your beautiful presentation, and it was really eye-opening. And I have one question and one comment. Question: as for protocol, HIFU treatment may decrease the lesion and maybe itself decrease HCG. And your protocol, 2 days or 3 days after HIFU, you do surgery, D and C. But I wonder, maybe 1 week later, it may be more easier. How do you think of it? Why do you decide 2 days after, 3 days after HIFU?
Okay, thank you, Professor Tsutsumi. So this protocol is all by our team, especially under the leading of Professor Zhang Lian. So because after the HIFU treatment, we know that we have the heat effect of the implantation area, and there has some the edema in that area. So the edema will be disappear within 72 hours. So we recommend that in these 72 hours, we do not do any transvaginal procedures for the patient to wait this edema to be disappeared or to be eased.
Okay. One comment. And if you have HIFU, you don't have to do uterine artery embolism, UAE, and because UAE may damage uterine function and also ovarian function. So HIFU is much better than UAE, it's my opinion. Thank you.
Yes, thank you. Thank you, Professor Tsutsumi. Yes, it's also what I'm thinking about is the HIFU, especially for the keep the function of uterine or the ovary function is better than UAE.
Yeah. Thank you, Dr. Tsutsumi, and thank you, Dr. Zhang. Because the time is limited, I know there's a lot of question and the need Dr. Zhang comment. Maybe you can go to Chongqing and visit to the Dr. Zhang and face-to-face to ask this question. The wonderful session, and no wonder Dr. Zhang is the HIFU mentor. So I need to close this session and give to microphone to the Dr. Tsutsumi. Thank you, Dr. Zhang.
Thank you.
So finally, thank you very much, Dr. Chan, and three speakers of Dr. Aizra, Lee, and Tam. And maybe all the participants enjoyed it very much. And will you please remember next 5 webinar will be held July 21st, third one. And I also remind you that coming September, we will have 22nd annual meeting of APAGE in Taipei, Taiwan. And I hope to see you face to face if possible. And anyway, it may be time to take maybe photo. Okay. Thank you for your cooperation. It's time to say goodbye and 再见。
再见，再见，谢谢。
拜拜，
拜拜。
关注风清。
Okay. Several time. Yeah, see you in Taipei.
Yeah.
Bye bye.
Yeah. Bye bye.
Bye.
Thank you very much.